Good day, everybody. Welcome to another exciting episode of the OIG Coffee Table.
Coffee tea. Yeah.
It's the coffee table. Last week we gave Matt a break. This week we're giving Wade a break. Wade is out on PTO at a wedding, and the ship still needs to be manned and sailed. So
You
Matt and I
never
are
get a
coming
break.
to you. What's that?
You never get a break.
I never get a break. I never get a break. Yeah, even when I get a break, I don't get a break, but that's all right. So Matt and I are here, as always. Matt Kachansky, Senior Director here of Payment Integrity, runs our SIU team, oversees all of the work that is done for all of our SIU clients from the payment integrity perspective. The retired Northeast UPIC Director and retired Special Agent in charge from the OIG. And I am still Eric Rubenstein, the Senior Director of Litigation, Fraud, Waste, and Abuse Support. And today we want to talk about an interesting premise. It's sometimes known as marketing the spread. And for those, there are essentially 3 or 4 categories of marketing the spread. One has to do in the pharmaceutical space, in which there's a manipulation of what's known as the AWP, or the average wholesale price. In some courts, they've actually called AWP ain't what's paid, because of rebates and things of that sort. So we're not going to spend time talking about that part of the metric of marketing the spread, because that's a little bit different. We're going to talk really about marketing the spread from the sales perspective. And I think what makes the most sense is for those of you that have done work with medical devices, and by medical devices I mean the equipment in a doctor's office, like a ultrasound machine or a transcranial Doppler, TCD machine, where the sales rep comes in and shows the doctor that if they buy this machine, what they could bill insurance for, and therefore make all of this money. And then what winds up happening is the device manufacturers put out suggested guidance, which you should never be following. And then all of a sudden, these people have all of these medical conditions that they didn't have previously. The other big one in marketing the spread is we're seeing some uptick in that involving the skin substitutes, at the amniotic skin substitutes, and you see that as becoming a thing. And then the other one is in physician administered drugs under the Medicare Part B as in boy program. Those are typically HCPCS codes that start with the letter J as an injectable. You see doctor infused drugs, for example. Drugs that require you to sit, almost like chemotherapy is a good simple example, but there are a lot of other drugs out there, drugs that are relative to things like Crohn's disease and the like. And the marketing, the spread, is where the sales rep comes in from the pharmaceutical manufacturer for these physician administered drugs, and they show the doctor what the financial benefits are by doing that. And Matt, the thing that always resonates is obviously there's a medical necessity issue. Do these people need to get these drugs when there are alternative drugs out there? Do they need to have a transcranial Doppler on their eye or things like that? So, but what always becomes interesting is from the data perspective, and I know we've talked a lot about this relative to treating diagnosis codes as the redheaded stepchild. And I'm sorry if you're a redheaded stepchild. I don't mean anything about that. But it oftentimes is that we tend to let the diagnosis code go at the wayside for other things. But there is an important part of looking at these diagnosis codes vis-a-vis the CPT codes, all relative to that care, meaning that, all of a sudden, and the example I'll give, and then I'll let you go to town on this, is I worked on a number of cases, and I know I've mentioned this in our podcasts before. There is an ancillary service called enhanced external counter pulsation, EECP G0061, I think is the HCPCS code for it. And it's basically for patients who have an unstable version of angina that is not treatable via surgery. And you need to have a cardiologist approve it, and you go to a place that gets it done. And I worked on a bunch of these cases where, lo and behold, the first day that the patient has the diagnosis of unstable stage 3 angina, whatever it is on the day they get the first treatment. And there's nothing previously that shows that they have that. And then on day one, they get it. And that's one of those instances where the data tells you the story, right? So let's talk about that. We're talking about whether it be like, well, for example, with the amniotic, the skin substitutes, that's kind of, sometimes it can be like shooting fish in a barrel, right? And then similarly with the devices, and that marketing the spread becomes the greed portion, because that's where the provider is going to see, well, if I buy this machine for $1,000, but I'm able to bill it out at 300 a piece, I'm going to make my money back very quickly, and it becomes a profit center.
Yeah, both with the IG and with the UPIC, we had lots of device cases, and a lot of them dealt with new devices to the market or established devices that all of a sudden had a different use. One of the ones, you talked about the TCDs. That was one of them where we had dozens of cases on those, and it was mostly with, going back to the data, it was with specialists that you didn't expect to be using the device, such as optometrists and ophthalmologists. And we would look at the claims data, and it was related to just their annual eye exam. There was no diagnosis of hypertension or any type of stroke symptom type of diagnosis. It was just part of their overall eye exam, the annual eye exam. And it was shooting fish in the barrel there. So, and what we found in that case, and in other ones like electronic acupuncture, where they put the little thing in your ear with a piece of tape, and they were billing for surgery, spinal implant surgeries, is the marketing of those wasn't just, word of mouth or, hey, you might want to do this, nudge, nudge, wink, wink. They had corporate pamphlets showing the spread. If you buy this at this amount, you can bill it X number of times with this code at this price, and here's your margin. So they were literally marketing the spread.
Yeah,
And I'm sure
that's pretty.
it's similar with skin substitutes on the data
Right.
with, why do they need skin substitutes? What is the history of that patient that shows all of a sudden they need these skin substitutes? And at what size? And do they have the prior services that were required to allow for the coverage of it? Did they have the debridements? Did they have the other attempts to heal that wound that failed? So now they have to use the skin substitute. All of
Right.
those things are within the data.
Right. Yeah, and I worked on a project here a couple of years ago. We did a self-disclosure on an ophthalmologist who was using a transcranial Doppler machine, and they gave him, the manufacturer gave him suggested diagnoses codes, and told him that in order for him to get reimbursed with this, that diagnosis needs to be the primary diagnosis. So what he was doing was he was flipping the diagnoses, making whatever the patient's real condition was the secondary diagnosis to ensure payment. And at some point, he realized that he was getting paid for these, and at some point, he actually didn't even have the machine operational, because he's just stopped doing it, because he was like, well, I don't need to do this anymore. I'm getting paid for this. So, that becomes, that's a data point that is of value when you look at that. And obviously, when you look at the skin substitute cases that are out there, OIG just put out a study that showed that there was a high propensity for fraud on this. There's some fraud alerts about it. It's been in the eyes of the SIUs for a number of years now, particularly with growing popularity. And again, it's not to say that there isn't a medical efficacy to something like the skin substitutes. I think we have to be able to discern differently that while something may have medical efficacy, it doesn't mean that you go right to it, right? When we
Right.
look at, for example, in the pharmacy space, oftentimes the PBM will deny the name brand top level drug, and they'll say we want step up therapy, right? Try before we're going to allow you to use this drug. And again, we're not here to argue right, wrong, or indifferent. there may be a great medical efficacy involving the use of that drug, but at the end of the day, that this it becomes a cost containment argument, right? That's really what it comes down to. It's cost containment. Is there a similarly situated class of drugs that will allow this to happen? And I think with the skin substitutes, there may be great value and great efficacy in using the skin substitutes, but the policies are the policies about what the process is going to be before you go to that. And I think what's happening is providers are looking at it and they're saying, well, the skin substitute is going to get me what I need. My patient is going to get what they need in 3 days, 5 days, whatever it may be, versus some other course of treatment that is not consistent with what that doctor might want to see. So going back in that data and looking at that diagnosis, does the person's first instance of a non-healing decubitus wound from diabetic neuropathy, well, that's a mouthful for a bunch of guys that aren't doctors. But, is that diagnosis been in existence for a year, 2 years? Or is it a recent diagnosis and lo and behold, the person got diagnosed with it and a week later there's a claim for the skin substitute? And the argument being is there, that timing issue becomes extraordinarily relevant to that. What do you see? And go ahead.
I was just going to say with the drugs, the patient's history is going to show what drugs were they on before for that same diagnosis. And is there anything in the history that shows that that drug was losing its effectiveness? And so if not, why the change to the more expensive one?
Right. Well, and the point there being is that if it's not broke, don't fix it.
Right.
And the argument, obviously, the counter argument is that people can develop tolerances. People can develop a resistance. I mean, these are things that the body does. And so there may be a medical rationale behind any of these things. But I think to me, the home run is like the person didn't have this diagnosis until the day they got this service. The person was diagnosed with this thing a day before or 3 days before. It's a little bit like the genetic testing, right? The genetic testing is generally the PGX testing, which is how your body metabolizes medications. That is typically a one and done test. When the fraudsters are out there selling the snake oil of you need to get this swab done to save your life, and they do it, and you've been on a statin drug for 20 years, that genetic testing is absolutely useless because you've been on this drug for 20 years and it's worked and it's done what you needed to do. What is the purpose of this genetic test? And I know I've talked on prior podcasts about a guy in New Jersey who was criminally convicted and went to jail for a number of years. So public record, his name is Seth Reifus. He ran a sham organization called Good Samaritans of America. It still sticks in my craw the way that he did what he did. But he was out there doing talks in senior citizen buildings and convincing them that they needed to get the genetic test, the buccal swab. He would say in his talks, 95% of you are going to be fine, but 5% of you can have an adverse event. Do you want to die before you get to see your grandchildren grow up? Like scare tactics, absolute scare tactics. Well, if I've been on a statin for 20 years, that test is absolutely useless. So I think that, part of this evolution of understanding, and again, the marketing, the spread, really, which is what the impetus is here, the marketing, the spread is, what did you buy something for? What can you bill for it and get paid for it? And does that make it worth the trouble? And for some of these, the dollar amounts are going to be very high. When you have, particularly, I think you see this with a piece of equipment, an ancillary piece of equipment, where once you've paid for it, it's free money. And I will loop this back. And I will loop it back to a recent LinkedIn post that I put up about a situation I had with the guy that used to be my primary care doctor. After 30 years, I fired him. And he was doing some things that weren't right. But one of the things that he mentioned in my discussion with him about what he did not being right was he said, well, as an example, when I did your physical, I did a life-saving test, an EKG, and I only get paid $17 for it. And I said to him, that's great, but the machine that you've got me on, you've had for years because it's the same machine. I see it. and it's been paid for 1 million times, and the person that's actually doing the test is a medical assistant, and the test results are automated. You're just looking at the test results. Like, let's not make this out to be more than it is. Even if the machine costs $4,000 or $5,000, he's had that machine for God knows how long. So, right, the spread that, he is at $17, he has paid for that machine a countless number of times, even at that low reimbursement. So that marketing the spread becomes the piece. Matt, as we wrap up, for SIU investigators, what are some of the things that an SIU investigator should be looking at two ways? One, from a data perspective, but B, when doing a request for medical records, and I think investigators sometimes fail to remember this, a request for records from the provider does not always just mean the medical records.
Correct. Okay, start with the data. You've got to look for things that are out of the ordinary. You mentioned one, diagnoses suddenly appearing, spikes in specific procedure codes or drugs or devices that are out of the ordinary for their specialty, or just out of the ordinary for their own history that they've started using or started billing for. Looking for relationships, referral patterns from that provider or to that provider from certain individuals, that you start seeing patterns of that might be ping-ponging, where they're bringing these patients, someone's in partnership, they bought the device together and they start doing these things. You have to start looking for those types of things. And when you open a case and you find something in the data that says this person is worth looking into further, when you get those medical records, look for invoices from the device manufacturers, the marketing materials from the manufacturers. If it's a device, invoices on, how many did they buy? If it's a piece of equipment, did they actually buy it? Get the invoice for that piece of equipment. Rental agreements with folks. So a lot of the TCDs, they were renting office space. These ophthalmologists and optometrists were renting space to the ultrasound people to come in and use the machine. Is there any type of rental agreements associated with that? So you have to look at that for those things beyond the medical records.
Well, and let's close it out with this. On-sites can have a great probative value. Does the machine exist? Is it in a closet? Is it dusty? When was the last time it was serviced? Make, model, serial number, right? What are the papers that you have? Now, again, we don't inherently recommend on-sites in some instances. We do recommend it in others. The one thing that we will always say is what we don't recommend is on-site surveillance. If you're going to do an on-site, your team should have a set of protocols, practices, and behaviors. They should be trained on how to do an on-site, everything from taking photographs to documenting the on-site. The one thing that we will always say is that investigators that are in this SIU space should not be doing physical surveillance as part of their on-site work or anything like that. We do that, and what we say is leave that to the professionals. We have professional surveillance investigators. We have professional we have the ability to professionally do video and audio and all of that stuff. So we're not talking about the same thing. We're talking about when your team goes for an actual on-site to retrieve documents, interview people, and look at it, because that's going to help you. If you go to a place where, for example, they're billing a lot of wound care kits and they don't have any, or TCDs and the machine is missing a wheel and it's in a closet.
Yeah, we had a lot of cases at the UPIC for tests involving tilt tables. We would go to the offices, they wouldn't have the tilt tables. So how were they doing the tests? It was easy to find, and the data showed it all in one visit to the office, and you had all the evidence you needed.
Right. So plan accordingly. Data is going to be your friend. Marketing the spread is a real thing. Maybe people do these kinds of cases. They just don't know that it is a marketing of the spread. And when we talk about marketing of the spread, we're really talking about when the sales reps are pitching their wares to the healthcare provider that they're looking to get into. So it's interesting, and I think we're going to see, these cases always exist. There's a lot of these fraud alerts out there about the injectables that are done, physician injectables, because at the end of the day, in some of these instances, the doctors need to have separate space, they need to have equipment. If you've got particularly long-term infusion drugs, sometimes there have to be refrigeration systems in place. You've got to have the proper chairs for people to sit in. They could be there for hours. Are you providing internet? Are you providing television? Are you providing snacks? Are you doing all the things to make what they're going through a little bit more comfortable? You see this in the oncology space or in the dialysis space. So it's in that same vein. So yeah, we're going to keep this conversation going. For those of you looking at data, it's a great way to start looking at data in a different way and kind of figuring out, what works and what doesn't work. So, Matt, as always, good insight. Everybody, as always, we enjoy spending our time with you, and the newsletter. We're actually in the middle of a refresh of the newsletter. You're going to see a brand new newsletter coming out with some new ways of looking at information. But as always, you can catch us each week on Spotify, on our YouTube channel. Just go right to YouTube, type in Advise Health, and subscribe to our weekly podcast. We've got a bunch of LinkedIn Lives coming in, and a lot of great things are happening. I know people are starting to gear up for NHCAA. We're going to be having some people there, and I know that's always going to be an exciting and fun time. So if you're at NHCAA, we hope to give you a wave and see you. And as always, Matt, good seeing you, and we'll see everybody on the next OIG Roundtable. Take care.
Thank you, everybody.